Hi, I'm Matthew Herzberg, and this is the Myopia Mindset. This is your weekly check-in for all things motivation, education, and inspiration on your path towards success with myopia management. And I am super excited about the episode that I have for you today because I feel like this one has been kind of in the making for me for most of my career. I remember the days when ophthalmology was very anti-myopia, very anti-Ortho-K, and we've made so much progress since then. And it is my absolute honor to have three outstanding, amazing pediatric optometrists who are coming from Ann and Robert H. Lurie Children's Hospital right here in Chicago. Welcome to the program, Doctors Magda Steck, Noreen Sheikh, and Shelby Johnson.
Thanks for having us.
Thank you for having us.
Thanks.
Yeah. And, what I meant by, my intro was that, I'm used to growing up in a pioneer Ortho-K practice. There was so much opposition from ophthalmology. And the fact that you are all doing myopia management at Lurie's and in the ophthalmology division, I think is absolutely outstanding. I remember being at Lurie's and being in that space and just being wide-eyed and had a huge grin on my face because we've made it so far in the industry. But before we get rolling on the episode, let's do contact information. Noreen, we'll start with you. If anybody wants to get in touch with you online, how can they do so?
Yeah, you can just look me up on LinkedIn, search my name, and send me a message or connect. That's the easiest way.
Perfect. And Magda?
I love LinkedIn option as well. So anyone can message me or just email me at mstec@luriechildrens.org.
All right. And Shelby?
And same thing. LinkedIn is the best. Check it once in a while, but I'm trying to be better about it.
Mm-hmm. And if you have any questions for me or anything we talk about in this episode, myopiamindset@gmail.com. If you want to support the podcast, do so on our Substack, myopiamindset.substack.com. Okay, let's get started. I want this episode to be a comparison about what it's like to do myopia management at Lurie's. And let's start with an overall view of the department and how busy it is, how many doctors you have working there. Magda, let's start with you. Give us an overview of Lurie's ophthalmology department.
Okay. Well, I have been at Lurie Children's for almost 2 decades right now, and I can't believe I'm saying that, but it's been almost 2 decades. And we're just super privileged to be in the division of ophthalmology. Our optometry department just welcomed our new addition, Dr. Shelby Johnson, this year. But we have an amazing, dynamic, diverse group of doctors, of ophthalmologists, and for optometrists. Everybody's extremely welcoming and definitely encouraging us to do a lot of myopia management. So our experience within ophthalmology at Lurie Children's was extremely welcoming to practice myopia management. They were very open. We knew that this is globally, obviously, this is a pandemic that will be affecting a lot of children and globally patients. So we wanted to be the leaders in the field. We knew we have extremely busy practice. And we wanted to have all the tools that we can have in the box to practice myopia, to be the leaders, to have a lot of research, to be very knowledgeable, how to pivot from one option to the other. And we are presenting at national meetings about myopia. We have a ton of research going on. So I'm super proud of the ophthalmology group and the optometry group to come together to fight myopia because it's everywhere.
Right. And go, if you can, go more into how this process started. Is that something that you all So, vocally, so we want to do myopia management. Is there a possibility of that, or was that something that came from the top down?
So I think myopia management or myopia practice for us started about 8 years ago, to be honest, and we were just taking like little steps. As I think one of the first options that we had was atropine, and so we started with that, but we didn't have too many studies, so we were slowly getting our patients into using it. Then, of course, we had the years of pandemic, and really what kind of, I think, set us apart here was just bringing on MiSight contact lenses to our practice. And I think everything just kind of exploded from there because we had more options to offer to patients. They were excited. We had been practicing with MiSight contact lenses really early on. So I think we were able to just kind of gain a lot of experience and familiarity with that option, as well as the other options that we had. But it took definitely some organization in terms of how to bring those tools to a busy practice as is already. But like I said, our division head was just extremely supportive of whatever options we had, whatever tools we had. I think we all had the same goal of just helping as many kids as possible, and just really bringing everybody working together as a team, having the same goals is what made this just really successful.
Right. Noreen, can you go more into like what is the myopia management philosophy of Lurie's? Like how do you approach it? Are you proactive about it? Like, is that something that, like, obviously you have these, we used to call them 4 alarm, patients, where it's like, we need to do something about it right now because this kid needs help right now. What is your philosophy for the division when it comes to every kid that comes in? Like, are you proactive about it? You can go more into that.
Yeah, that is a good question. And one of our challenges is that a lot of our patients are low income. We see a lot of public aid patients, and unfortunately, without any insurance coverage for myopia control treatments, it can be challenging, right? And we've had many conversations about, do parents feel pressured? Like, can they afford this? We worry about, like, can they, should we be offering it to everybody, or should we be offering it to the patients that we see progressing? And, over the years, what we've realized is that parents put their kids first, right? And if there's something that they can do to help keep their kids' eyes healthy, they will do it. And it's important. And I think that it's really, we try to be very fair in the sense that we know that we have this great toolbox. We're not going to limit it to certain people, right? It should be available to everybody. And so we offer it to everyone in the sense that it's not necessarily the highest myopes, it's the patients, and not the fastest progressors, but even those pre-myopes who we might see progressing. Some of them might have the habits that make them more likely to progress, but we don't necessarily know it as well as their parents do. And so really our philosophy is to offer that toolbox and to educate families about what their options are.
Yeah. And is that like an all hands on deck? Like, Shelby, you're the newcomer to the program. You've been there for about 3 months now, but you have a lot of experience already in Ortho-K and myopia management. So is it like an all hands on deck? Like what I mean by that is I've seen in a lot of like multi-doctor practices, or even multi-location, if it's a practice network, it's like not everybody is, has this throughput on the messaging of myopia management. And I feel like a lot of the times patients are slipping through the cracks if, not everybody is on the same page. So what is your, like, coming in, like, what is your interpretation of the program?
Yeah, that was one of the things that drew me the most to Lurie's. Was during my initial interview, I wanted to make sure, because, I have also worked with ophthalmologists who were skeptical about it. And, talking with Magda, that initial interview, she was like, we do all the options, we do everything. We're so excited. We do these research projects. So it literally was a seamless fit. And all three of us, plus Dr. Kellyanne, who's the fourth optometrist who couldn't be here today, I feel like we all practice very similarly. We all really advocate for our patients. And then we get, the ophthalmologists send their patients constantly. They just say, follow up with optometry for myopia control. And they hand off the reins and we take control. Very collaborative efforts. We have our administrative people who are super helpful. Nurses know about it, are on board. They can answer questions for patients. So it really is such a collaborative environment that I feel like patients, no matter who they talk to in our division, they're going to get a consistent answer. And that answer is that, yes, it worked.
Mm-hmm. Yeah, I love that, especially, with you mentioning all the different components that come into play. Magda, being in a children's hospital, is there a lot of crossover? Do you work with other specialties in the children's hospital? Is there any kind of connective tissue that normally where, you have that option? Like I'm thinking of like the crossover potential with like pediatricians, for instance, and is that a component at Lurie's?
Absolutely. I think our huge part of our success is because we from the beginning started to collaborate with a lot of pediatricians, write letters, constantly communicate with them about the new technologies. Dr. Sheikh and myself had a lot of myopia webinars and other podcasts for the pediatricians specifically for it's called Pediatric Pearls program through Lurie, and it's not only informing like the pediatricians within the Lurie system, but it's informing pediatricians across all networks in the community also. So I think that having this communication and informing other professionals about what we do and what's available is huge. In addition to pediatricians, we also collaborate with the other specialists in our hospital. So we collaborate with cardiologists if we need to ask a patient if the patient can use atropine drops, or sometimes neurology, and we send the patients back and forth if they, for example, have high progressive myopia and maybe there needs to be genetics involved and retina specialists, and maybe they have strabismus and everybody needs to be involved. So yes, we work as a team. We have amazing team that is really enabling us to really see any patient and just come up with the best plan for them. I'm grateful for that.
Right. And I'm wondering if we can give any kind of like advice, because I'm often running into this obstacle with optometrists who don't know how to approach pediatricians or other specialists. So is it just simply having the children's hospital connection, or was there like a secret sauce as far as like, here's how we need to approach a pediatrician? Noreen, if you could elaborate kind of like on that approach, since it's a collaborative effort. What kind of like pearls can we give for this is how you approach another specialist, or this is how you approach a pediatrician, or even another optometrist who may not be doing myopia management?
So I think one of the things that's been very effective is sending a note. You see your patient in your clinic, and then you have your clinical notes. You send a letter to the pediatrician with the summary of your evaluation, and include in that the recommendations, the myopia control recommendations, or whatever else it may be. So I think that professional direct communication is very beneficial. The other thing is pediatricians appreciate meeting us, right? Like they want to know who are the specialty providers, like who else is treating these patients, who can they refer their patients to for help. So if you have time is of the essence, right? Pediatricians don't have a whole lot of time to sit down and have lunch and talk about it. But if you have materials that you can share with the pediatrician with your information on it. I think that that's beneficial too. We have a little myopia control portfolio that we've created for our department. And so we use that to educate patients, but it would be just as beneficial to educate pediatricians.
Mm-hmm. Yeah. I'm always curious about like how we can improve, this referral system, because oftentimes, like Paul Levine says, the biggest crime in optometry is patient referral. Like optometrists themselves do not want to lose their patients to a doctor who's doing myopia management, but we're not putting the patient first in that circumstance. And that's really, I think, the true crime of the situation. Shelby, walk us through what like the workup, the baseline workup for pediatric myopia patient at Lurie's. Like how you've got such limited time to work with a patient. So like, what are we on the lookout for? How do we address that once we find it? And does that process move to like another step with a consultation, or do you have just that short period of time to work?
It's a good question because I feel like it can vary. So the first step really is having amazing technicians, which we have. They're able to collect data that we do need. And so that's really helpful. And then the second thing is taking a really good history. So getting the information of their hours of near work, their outdoor time, and family history, really assessing the risk. So that way, even if we have a short time, say for education, we're able to go in with these answers or these risk factors, let them know if this is what's going on. I've had multiple patients who have, they've come in, either they've heard about it, they were referred for it. Those ones are kind of the easier sell. Some that maybe need a little bit of time. Really nice that we are on the Epic EHR system. So patients could, message through there and say, hey, I've discussed it with the rest of the family. We want to start this treatment. What are the next steps? And we're able to schedule them and things like that. We offer telemedicine appointments, which I think is really beneficial to answer those further questions. Yes, we can't answer everything in the moment. We provide them with information when they walk out the door. They can read a little bit about it, discuss as a family, and then they reach back out with questions during the telemedicine appointment. And then having a really good conversion rate to them starting treatment and being able to follow them.
Right. And go more into the process of that conversion. I'll open this up to the whole panel here, but how are you having these conversations? What kind of treatment modalities are we offering? And how does that usually go? I think that one of the biggest obstacles, I keep beating this drum over and over again, is like docs simply just aren't talking about myopia management with their patients. And I think given that your demographic has that low income element and there is that barrier that's like, well, we should be talking about this with everyone. So go more into that. Shelby, start us off. Like, how does that conversion system work? Yeah.
Mm-hmm. So I think really for me, it's always been getting to the root cause of why it's important to do so. Parents, I had a parent literally cried today, her 2-year-old. It was related to astigmatism, wasn't even related to myopia. And she started tearing up because her child might need glasses in the future. So parents do really care, and getting at the root cause of why it's so important to help slow it down, right? Like, yes, they could get LASIK when they're older. They could wear contact lenses. But I think for me, it's always been helpful to really take a step back and be like, the reason that we're having this discussion today is that we want your child to have good vision their entire life. And so it may be more time intensive, money intensive early on, but this is going to ensure really your child's visual success in the future. So for me, I think coming from that starting point, even if it maybe they don't convert at that visit, I feel like once they've thought about it, read more about it, then the chance is much higher.
Yeah. Noreen, what is a part of your process? Shelby had mentioned if it's not at that visit, what I'm used to, the practice I grew up in, we would work on parents and patients for 5 years before we typically saw a conversion. And gladly, things are different now. In the very beginning with myopia management, Noreen, did you have hesitancy to bringing it up, or did you just, push through that opposition or that rejection to get towards the goal of like, look, everybody needs to hear about this?
Yeah, it's funny. It really has evolved because a lot of parents are familiar with it now, but in the beginning, that was not the case whatsoever. And so I find myself, because you never know, right, who's sitting in your chair, like how much do they know, right? So whenever I see a child who is myopic, then I pull out, I've got a little one pager that has an image of an eyeball, and I say, okay, this is a normal eyeball, and this is a myopic eyeball. It's a little bit longer, right? So then I'll explain like anatomically what's happening, and so many parents' minds are blown. Like they had no idea that their eyes were longer, and this is why they can't see properly. So starting with the basics, and then from like a time perspective, I hand them the information and I say, this is a quick overview of the treatment options. This is what we're trying to do. We're trying to slow down the growth of the eye, and this is the cost of everything. Call your insurance companies and try to advocate for them to cover it, but nothing's covered right now. This is what I would recommend, and go home and talk about it, and you can decide. And so sometimes they'll convert right at that moment, or they'll need to confer with dad or whomever and come back and make a decision.
Mm-hmm. Yeah, it's usually mom that we have these conversations with. And sometimes we forget that there's this other component, mom, there may be, her husband or the father of the children, and they're not in the same household or whatever the case may be. And this conversation needs to happen again. And it's difficult because mom was in that appointment with y'all and dad or the other person was not. So then it's up to that part of the conversation. Magda, can you go more into like what kind of treatment options you're offering? Because there's so much on the table right now. We've got Ortho-K and atropine, and we've got MiSight, and we've got now Stellest, the glasses, the anti-myopia spectacles. Is Lurie's making use of all of these, or because I found a lot of practices they stick with a couple of treatment options. The one I'm used to is Ortho-K, obviously, but is Lurie's offering all these treatment options?
Yes. So the simple answer is yes, but I will go back to the previous questions a little bit too. And I just want to emphasize like confidence of practitioner too. I think the more confident we are as practitioners and know about these options and the benefits and just kind of why we would offer like a soft contact lenses versus Ortho-K versus, glasses versus atropine. So just like know your pros and cons of options, and also keeping like the cost in your mind, and that's really important to just offer the option to that patient when you're really confident about it. And I feel like this is like one of the kind of like the biggest, transition or having the patient use myopia control option is when I am really offering something that is really customized and fits that patient the best. So I just really want to emphasize that. But to answer your question, yes, we are lucky to offer all the options. Okay, so we're offering the low concentration atropine. We're offering the peripheral defocus contact lenses. So MiSight, natural view multifocal. A lot of the patients that, for example, may have high astigmatism, we still offer, Biofinity toric multifocal option. We offer Ortho-K option. We offer, now FDA-approved Stellest lenses. And we have actually been offering these lenses even slightly before that. So I don't want to maybe get into that, but yes, I've been getting patients who were coming from, Asia and Europe and Canada. And so even though there is newly approved option for US, we already have probably 2 years of experience with these kind of lenses already at Lurie.
Yeah. What has that 2 years of experience taught you about, the spectacles or really any other treatment?
Yeah. So I think number one thing is you really have to look at the patient and really kind of customize the treatment for the patient. So really depending on the age. So for example, simply we may think that, a 6-year-old minus one, 6-year-old maybe best fitted with the glasses, but we really have to think about, well, will this 6-year-old wear these glasses full time, or where they just still wear them kind of as needed? So, maybe the drop is better option. I've been actually surprised with many 5-year-olds and 6-year-olds and even some younger patients that, before we had glasses, I fitted them with contact lenses, and the families, those were obviously families who have high myopia and didn't want their kids to end up really highly myopic, but they were really excited even about contact lens options. So honestly, I let my patients choose what their best option is. I make sure that I offer them all the options and just kind of try to guide them and listen to what the needs are of the patient. Are there swimmers? Then, Ortho-K would be an amazing option for them. Will they wear glasses full time? Or is this patient just starting with the glasses and maybe they need to start with the drops first? Or are they transitioning from elementary school to middle school and they want to look cool and they don't want to wear glasses? So really trying to listen to the family, but because the best option is going to be the one that they're going to use. So I think that's kind of like my pearl. Just offer something that you think the patient's gonna use, and then be confident in what you're prescribing, just generally what the mechanism is. When I draw out, so to Noreen's point, when I draw out how the technology, either in glasses or the contact lenses, what they're kind of doing to the eyes, the parents has like no questions after that. They're like, yes, I want the treatment. I think this is going to be a great option for my kid. And they're doing it.
Yeah. Okay. So I'm fascinated by this because this is a, like there's a divide here. There's a portion of docs doing myopia management who say like, I recommend the treatment. I tell them, I definitely present them with options, but I'm leading them in a certain direction of what I think they should be wearing. And then there's another section of, docs who are like more akin to what you just said, Magda, where it's like, I'm letting them decide. I'm reading the patient, the situation, because, and I think you made an excellent point, you want the system or the treatment that's going to work best because that's the one that they're invested in, right? So I think it's fascinating that you have these two sides. I don't think one is more right than the other. Shelby and Noreen, do you use the same? Is that universal in at Lurie's? Is you do the same thing? You leave it up to not leave it up to, but you have your recommendation and you read the patient, their parents, and let them decide.
Yeah, for me personally, I've kind of always subscribed to that because the whole family has to be on board. I could make a recommendation, and if the child's not ready for contact lenses or the family doesn't have the time in the morning to help the child put in the lenses, right, based on their lifestyle, it's not going to be successful. And so you're, really spending a lot of time and money when we're not going to have a good outcome. So and I do discuss, I bring up all options. I might say you're not a good candidate for Ortho-K because of, whatever reason, but I let them know that it is an option in case they go home, look it up, and they get mad why you didn't introduce it. I'll let them know what they are a good candidate for. The number one question I get asked is, well, what should we do? Which option should we pick? And I let them know exactly what Magda said, which option everyone's going to be on board with, you're going to be the most adherent to. If you're going to forget the drops 3 days a week, they're motivated to wear contact lenses, well, then we probably have.
And then just to piggyback off of that, the other thing is parents will ask, which one's the best? Which one works the best? And that's the conversation we have. One is not better than another. The one that you will use is going to be the best option. And so when I'm having conversations with patients and parents, and that's usually part of it. And then also as far as like leading the patients, right? I don't necessarily lead them, but I will have a conversation about the pros and cons of each. And so based off of their responses and what their lifestyle is, I might recommend one just based off of that, but it is truly their choice. I just let them know what the pros and cons of each are as far as the lifestyle is concerned.
Right. And go ahead.
Sorry, and actually to add to this like myopia control is a process, is a dynamic process. So we start the control when they're 4, and then things may change when they're 6. Things will change when they're 8. They will change when they're teenagers. So I think really just kind of, walking the path of this patient throughout the whole process, I think is what the key is. And since we have so many options, we also, as practitioners, need to be able and be very confident from changing from one option to the other also.
Yeah. Yeah. Yeah, if y'all can go more into that too, because I feel like that's one of the advantages that we have now with atropine and the spectacles specifically, is that you can start with something and then see how that kind of goes, and then introduce something if that's not working or if the treatment option needs to change. So if y'all can go more into that, I'll open it up to the panel. Like, is that a process? Is that kind of in the back of your head of like, well, I know I can start with this, and this is my go-to treatment. Like, I don't know if I don't want to make like a situation uncomfortable, like asking like, do you use more of this product or more of this product? So we'll keep it, I guess we'll keep it generalized, but like, is that the case? Like, do you have like a go-to treatment option? Like, I know some docs are more into Ortho-K, for instance. Ortho-K is their bread and butter. And then there are some doctors it's like MiSight is is their go-to treatment modality. So Shelby and then Noreen will, and then Magda, we'll start with you.
Yeah, so I don't have a preferred treatment modality. I've been really lucky since residency in 2017. I've used all modalities a lot, and so feel comfortable. And that's another very common question from parents is, well, what if they don't want to wear contacts anymore? What if they want to get into contacts later? So letting them know, I think, can be really helpful. I think they're a little less hesitant to jump in when it's not a forever thing, or you're not locked in, So
Right.
I think they'll be a little more willing to, hey, let's try this out. Let's see how it goes. And we can always switch if they don't like it, or we can always add something in if it's not as effective as we would like it to be. Um, So yeah, I think that it can be really beneficial for parents to know that, and that also can be helpful in getting them started in the process. But like Magda said, like being confident in switching, or know when to switch, or know when to add in, um, is really going to also help the patient feel more confident in their choices.
Right. Yeah, Noreen, what do you think?
Yeah. I don't have a go-to treatment at this point. I will say it's evolved sort of organically, right? Like what my recommendations have been based off of what's been available, right? And what the data has shown us. Like we started our myopia control clinic was 2020, I believe, when we first opened it or kind of built this. And so, we started with 0.01% atropine, and then the studies came out and we realized, we shouldn't be using 0.01, we should be using 0.05 more. And so, and then when MiSight came out, that became another option. And so all of these things have sort of evolved. When we got our new division head is when we were able to introduce Ortho-K, because she was very supportive of us trying it, right? And implementing it into our myopia control practice to help us sort of build and have a well-rounded toolbox. And so, at this point where we stand now, there's no sort of go-to treatment necessarily. I think we all sort of prescribe it based off of the patient and customizing that treatment. But it certainly has evolved as myopia control has evolved.
Right. Yeah. Magda, what do you think?
Yeah, I mean, I agree with both Noreen and Shelby. I would say that for a lot of my patients, actually, FDA approval is kind of like a big point for families. So even if, I present all the options, they would say, well, which one is FDA approved, or is one FDA approved versus another? So I think that is kind of like a big point that my families are focusing on, having that FDA approval option. I think for me personally, I think like having objective data. So we're lucky to have axial length capabilities, measuring capabilities. So I think following that and whatever treatment the patient is on, as long as the axial length is showing the treatment is working, if the family is happy, then we stay on the treatment. If, for example, family, like let's say they've been in contacts and now they want to wear glasses to be more fashionable more, then, we do, 50-50 or 70% of contacts, 30% of glasses. So, I mean, honestly, it's really a fun playground to be in right now because you can really be creative and honestly, don't be afraid to be creative. I think as long as the patient is happy, the treatment is working, and everybody is feeling like this is the right choice for the patient, I think that is the right approach.
Hi there. I hope you're enjoying part 1 of this episode. Part 2 is going to be available next week for our paid subscribers. And this is the part of the podcast where I would be taking a quick break to tell you about one of our sponsors. But the simple fact of the matter is, we don't have any sponsors. The Myopia Mindset survives exclusively on the generosity of its audience, listeners and viewers just like you, who either believe in our mission to spread the word about how awesome myopia management is, because we need more ECPs online doing it and doing it confidently and doing it successfully. Or maybe you're one of the audience members who have been learning from our content directly. Or maybe you listen to the podcast as part of that motivation and inspiration aspect to it. You listen to it on the way to the practice. I've heard from some of you that do that, or you're listening to it while you're walking the dog, or you listen to it while you're winding down for the day, or while you're closing down the practice. And if the Myopia Mindset is a benefit to you, if you are interested in becoming a paid subscriber, you can do so on our Substack, myopiamindset.substack.com, the cost of which is just $12 a month, which I said, hey, that's the cost of a cup of coffee each and every week. And if you would buy me a cup of coffee to have on amazing guests to nerd out about myopia management, then please consider becoming a paid subscriber of the Myopia Mindset. You can do so on our Substack. Like I mentioned, paid subscribers are going to get part 2s of every single episode that we do. But we've also started doing articles on our Substack. I've been taking a year's worth of content. I've been making clips. I've been putting them in front of Carrie, and I've been saying, hey, can you give us like a short article, a short piece, write a little something about this particular topic from your perspective. Carrie has over 40 years of experience in myopia management. He's one of the pioneers of our industry, and he has been writing some great content. It has been really working out really, really well. If any of this is appealing to you, then please consider becoming a paid subscriber of the Myopia Mindset. Myopiamindset.substack.com is how you do so. Thank you so much. Let's get back to the episode.